moving on to types of movements. So linear motion is basically gliding motion, one bone sliding over the surface of another bone. An example would be in the wrist, the carpals, some of the bones in the tarsals and the ankles, and the clavicle and the sternum. Those bones just simply glide past each other. More common are angular motions, abduction and adduction. Abduction is movement away from the longitudinal axis, or like the midline of the body. If you raise your leg up or move your arm up away from your body, that is abduction, or you're abducting that limb. You can do that also with the hand at the wrist. You can abduct it, move it away from that longitudinal axis of the arm. Adduction is the opposite, dropping the arm back towards the midline or the longitudinal axis is adduction. Think of it this way: you're adding that limb back to the midline, or adducting the leg back down, or at the wrist, adduction. More angular motions: flexion, extension, and hyperextension. Flexion, you're decreasing a joint angle. So if you're in the anatomical position, that's a straight line, 180 degrees. If you flex the neck, you decrease that angle. Same thing with the elbow, straight line, 160 degrees. If you flex at the elbow, you are decreasing that angle. Flexing at the leg, you're bringing that leg forward. Or flexion at the wrist. Extension is the opposite, increasing the angle. So to bring the head back into anatomical position, you extend it, or you extend the forearm at the elbow, you extend that joint, or extending the leg back, and you can even extend it further, which would be hyperextension. Extension beyond the anatomical position, looking way back, hyperextend the head at the neck, hyperextend the leg at the hip. Circumduction, another angular motion. One point is stationary, and the other end describes a circle, like at the shoulder. You can do that at the hip as well, circumduction. Rotation, rotating about some axis along the longitudinal axis, like in the head or here at the shoulder. Head rotation, for example, or lateral, which means also external rotation of the limb at the shoulder. You can do it at the hip as well. If the toes are pointed forward, but you laterally or externally rotate the leg, then your toes will be pointing out to the side. Medial or internal rotation is the opposite, bringing the arm over, like so, or bringing the toes pointing inward would be medial or internal rotation of that lower limb. More rotation, this is at the elbow. Pronation and supination. With pronation, you move the forearm such that the palm is down or the palm is facing backwards if you're in the anatomical position. And then supination, you're putting the palm, the arm, the forearm into the anatomical position facing forward. And in supinated position, or when you supinate, the radius and ulna are parallel to each other. When you pronate, the radius rotates over the ulna. Like so here, this little diagram, pronation, pronation, supination, pronation, supination. Maybe a way to remember it, if you were going to bake for soup and you had your palms up, your forearm needs to be supinated, palm up, so you can cup your palm and hold the soup. Supination, soup in your hand. At the ankle, eversion and inversion. With eversion, the sole of the foot points outwards. With inversion, inwards. So if you were to say trip and twist your ankle, which is most likely? You're going to most likely do inversion of that particular ankle. Dorsiflexion, plantar flexion. With dorsiflexion, as if you were to take a step forward, you have to lift your toes, elevate the toes, otherwise your toes would drag on the ground. Once you take a step and you go to push off, then you do plantar flexion, toes down, pushing off the ground. Or if you were to kind of go up on tiptoe to look over a fence, for example, that's plantar flexion. At the hand, the pollex or the thumb, phalanx 1, opposition and reposition. To oppose the thumb opposition, you go to touch tips of the digits, and to put the thumb back into the anatomical position is to reposition. Vertebral column, bleeding the neck. Lateral flexion, bending to the right or left. That can happen at the neck or on the vertebral column in the torso, like if you're doing side bends. Lateral flexion. With protraction, you're moving anteriorly along a horizontal plane. So if you're jutting your jaw forward, you're doing protraction. Retraction is the opposite, movement posteriorly along a similar plane. Like if you're moving your jaw back, you can protract your jaw somewhat. Elevation is to elevate the jaw, as you see here, like if you're going to bite down or chew gum. Depression is the opposite, dropping that down, like if you're opening your mouth to stick a piece of gum in your mouth. Depression. Notice at the scapula at the shoulder, we can do the same thing. Can elevate the scapula or depress the scapula. Protract or retract the scapula. If you move the scapula forward, like if you're moving your arm forward and maybe reaching across your body, you're going to protract the scapula. Retract it would be to, where's my cursor? Retract it would be to bring it back from the anterior position, moving it back to the posterior. And notice in the scapula, you can even do upward and downward rotation because there's so much movement at the shoulder. If you remember, the pectoral girdle attaches to the axial skeleton just at one spot. The sternal end of the clavicle at the manubrium of the sternum. Okay, let's get into our figure 8.2, gliding or plane joints. These are when bones have flat surfaces, like the carpals and tarsals in your wrist and ankles, but also the sternoclavicular joints. Sternal end of the clavicle with the manubrium of the sternum, that's a gliding or plane joint. Monaxial motion, meaning they just glide past each other. A hinge joint, like at the elbow, or at the knee, or at the TMJ, at the jawbone, temporal mandibular joint. There's one motion, monaxial. Interphalangeal joints are the joints between the phalanges, or the digits. So those are the distal joints in your fingers. So keep your palm stationary, stick your hand in front of your face, keep your palm stationary, and just move the fingers. Notice how they flex, extend and flex at those joints. That's a one angular monaxial motion of those hinge joints. Excuse me. Pivot joint, cone-shaped surfaces of some sort. The atlantoaxial joint. Remember, the axis rotates about the atlas rotates about the axis at the dens. Also the proximal radial ulnar joint. Remember pronation and supination, because the head of the radius is in contact with the capitulum on the humerus, allowing that type of pivot joint there for supination and pronation. Condylar or ellipsoidal joints. You have kind of a concave, convex, or oval depression surfaces on those two articulating bones. These are occurring at the metacarpophalangeal joints. Like, where's that? Metacarpo, so the wrist. Sorry, metacarpo the bones in the palm of your hand, fleshy part, and then the phalanges are the fingers, 2 through 5. 2 is the index finger, 3 the middle finger, 4 ring finger, and 5 is your pinky, not the thumb. So those are condylar joints. A lot of motion there, biaxial. And also the radiocarpal joint with the radius scaphoid gives a good amount of motion at the wrist there. Moving on to saddle joints. And again, convex or concave surfaces, a little more elaborate. This is at the first carpal metacarpal joint. So the first carpal metacarpal joint, that's at the wrist with the metacarpals, and the first one, so that's at the thumb, base of the thumb. That allows for opposition and reposition of the thumb, biaxial movement. Ball and socket joints, round head and a depression. Shoulder and hip joints are this type. The hip joint is a deeper depression, and a lot of range of motion here, actually triaxial motion. Okay, let's move into the TMJ joint, temporal mandibular joint in the skull. The mandibular fossa, of which bone? Right in here, temporal bone. And then the condylar process of which bone? Mandible. There's an articular disc in there, helps cushion the joint. And there's a relatively loose capsule that allows a good range of motion with this joint. So it's a hinge joint, but remember you can protract, retract the jaw somewhat, move it around. Think about the action of chewing gum. It's not just up and down, but you can move that mandible forward, protract it, move it back a bit, retract it. But it is a hinge joint. Okay? A good amount of motion for a hinge joint at our TMJ joint. Glenohumeral joint. Glenoid fossa or cavity of the scapula and the head of the humerus, the shoulder joint, or humeroscapular joint. It is a ball and socket joint. It's fairly shallow, which is one reason why you have a huge range of motion there, but that means you lack stability. There is a cartilaginous glenoid labrum that helps deepen the socket of the glenoid cavity to give some reinforcement of this joint. The articular capsule extends from the scapular neck to the humerus, and we'll see that in the diagram. Most of the stability is by associated ligaments and skeletal muscles with their tendons that reinforce this joint, and we'll see that in a bit. We'll see that now. Okay, so the glenohumeral joint, this is looking at it from the anterior aspect, from the front, and this is the lateral aspect with the humerus missing from the side here. Okay, figure 8.7. So the only thing you need to know here is what I have highlighted with the little red dots. So that's the scapula here. It has some protuberances. Here's the coracoid process. Remember C on scapula, another C here, coracoid process on the scapula. Over here is the acromion on the scapula. On the side, acromion there, and there's the coracoid. There's the clavicle here. And then there's the humerus missing on this side. So the bones that you need to know for the shoulder joint. Excuse me. There's the articular capsule cut open here, reinforced by the glenohumeral ligaments here, which are cut here. And the shoulder joint is also reinforced by the subscapularis muscle that goes from the muscle here, that's the subscapularis muscle here.